All right, today we're putting on our detective hats. We're going to tackle a medical mystery that, believe it or not, affects millions of people but is so often misunderstood. We're cracking the case of the chronic wound. And our entire investigation, well, it kicks off with one single really frustrating question.
You know, it's a question that can be so frustrating and frankly, pretty painful. A simple cut, a scrape, usually your body just takes care of it, right? But then there are these other wounds that just stop. They get stuck. So what's going on? Why does the body's absolutely incredible healing process sometimes just break down? That's the mystery we're here to solve.
So first up, let's get our terms straight. A chronic wound isn't just an injury that's taking its sweet time to heal. No, it's a wound that has become completely trapped. It's stuck, unable to move through the normal stages of repair. And here's the most important thing to remember. This isn't random. There is always an underlying culprit, and our job as wound detectives is to find it.
And yeah, that's exactly what we're going to do in this explainer. We're becoming wound detectives. We're going to look at the evidence, follow all the clues, and identify the different culprits hiding behind these incredibly stubborn wounds. Because here's the bottom line. Once you know the cause, you know the solution.
Okay, let's open up our first case file. We'll call this one the circulation culprits. Our investigation starts down in the legs, which is where a lot of chronic wounds show up, and it's usually all about problems with blood flow. You can think of it like the body's plumbing system. The problem is almost always either a backup or a blockage.
So here they are, our two main suspects. First, you've got the venous ulcer. This is the backup problem. The veins aren't working right, so fluid starts to pool, making the leg feel heavy and achy. You got swelling, staining, it's a mess. Then you've got our other suspect, the arterial ulcer. This is the blockage problem. Clogged arteries are literally starving the tissue of blood. These are intensely painful and look like they've been punched out. So yeah, they might both be leg ulcers, but they leave behind two very, very different crime scenes.
Okay, so how in the world do we tell these two culprits apart? Well, we have a key piece of diagnostic evidence, the ankle brachial index, or ABI test. And it's actually beautifully simple. A clinician measures the blood pressure in your arm, then they measure it down at your ankle, and then they just compare the two. That simple ratio tells a crucial story.
And boom, here it is, the smoking gun. If the pressure in your ankle is way lower than the pressure in your arm, giving you a ratio of 0.9 or less, that's our signal. It points directly to a blockage. It confirms something called peripheral arterial disease, or PAD. That one little number tells us everything. We know for sure we're dealing with an arterial problem, not a venous one.
And this is why this all matters so much. Getting the diagnosis right is everything. For that venous ulcer, the backup problem, the best treatment is compression. Special bandages that help push all that pooled fluid back up the leg. But, and this is a huge but, if you put that same compression on an arterial ulcer, the blockage problem, you could cause a catastrophe. You'd be squeezing off an already tiny blood supply. This is why our detective work isn't just an exercise, it's absolutely vital.
All right, let's move on. Time for our next case file. Sometimes the wound itself isn't the main crime scene. Sometimes it's just a clue pointing to a much bigger problem happening all over the body. These are what we'll call the systemic suspects. And the most notorious of these is the diabetic foot ulcer. This is rarely a one-person job. Oh no. This is a crime committed by 3 co-conspirators, all working together. First, you've got nerve damage, which means a person might not even feel a small cut or a blister. Second, there's poor blood flow, that same arterial disease we just talked about. So the body can't get healing supplies to the area. And third, you often have foot deformities that create these dangerous high-pressure spots. It's a true triple threat.
So when you're up against all that, what's the #1 rule? What's the most important thing for healing a diabetic foot ulcer? It's this one single powerful word, offloading. It just means taking all the pressure off the wound, period. You could have the most expensive, most advanced dressing in the entire world, but if the patient is still walking on that ulcer, it will not heal. We're talking specialized casts, boots, shoes, whatever it takes. It is the absolute non-negotiable first step.
Now, let's turn to a really different kind of case, a malignant wound. This is a wound caused by a cancerous tumor that's actually broken through the skin. And here, our investigation, our whole approach, it has to shift.
The goal isn't always to cure the wound itself. Instead, the focus becomes palliative. It's all about managing symptoms like odor and pain to give the patient the best possible quality of life. The very definition of success changes. It becomes about comfort and dignity.
All right, time to open our final case file. This time, we're looking at wounds that aren't caused by some internal failure, but by outside physical forces, things happening to the body.
And the classic example here is the pressure ulcer, what some people call a bed sore. It's caused by just prolonged pressure, usually over a bony spot like a heel or the tailbone. That pressure cuts off blood supply, and the tissue starts to die. The damage happens in stages. It can start as just a little patch of redness that won't go away, but then it can turn into a blister, then a shallow crater where you can see fat, and finally, a deep, terrible wound where muscle or even bone is exposed.
Because these pressure ulcers can get so bad so quickly, the best strategy isn't treatment, it's prevention. You have to play offense, and that means regular repositioning for people who can't move themselves. It means using special mattresses and cushions to spread out the pressure. It means taking really good care of the skin and making sure nutrition is optimized. In this case, it is so much easier to prevent the wound than it is to heal it.
And finally, let's take a quick look at surgical wounds that don't heal right. It's just another case that demands an investigation. You know, the most common culprit is just a plain old infection, but it could also be a hematoma, which is a collection of blood under the skin. Or maybe there's too much tension on the stitches, or just not enough blood supply getting to the site. Once again, you have to find the specific cause to fix the problem.
So, we've gone through all the evidence, we've looked at the different case files. What's the main takeaway from our whole investigation? What have we learned?
Well, our investigation leaves us with this, a final detective's checklist. Number 1, always check the blood flow with an ABI before you even think about using compression. Number 2, for diabetic foot ulcers, offloading is the absolute non-negotiable first step. 3, for venous ulcers, consistent compression is your key to healing. 4, for malignant wounds, you have to shift your focus to symptom control. And 5, for any post-op wound that's gone wrong, find the cause. Is it infection or is it something else? The big takeaway is crystal clear. A chronic wound isn't just one thing. It's a clue, and it demands a proper investigation.
So by understanding the why behind each of these different wounds, we've basically figured out how to crack the case. But, that leaves us with one final and maybe even more important question. Now that we know the culprits, poor circulation, uncontrolled diabetes, prolonged pressure, how do we use that knowledge not just to treat these things, but to stop these crimes against healing from ever happening in the first place? And that's the thought I'll leave you with. Thanks for joining me on The Explainer.